When EMS arrives for a patient with a risk for a hip fracture, most of the time it'll be obvious. Usually the hip will be externally rotated and the leg will be shortened. So that in and of itself is a very obvious sign just on first observation. The other important clues on physical examination is that a patient who is demented and won't bear weight should be considered to have a hip fracture until proven otherwise. So they may not have any displacement, they may not have any rotation, but they usually will have tenderness. Frequently the patient will have tenderness on a hip roll or log roll, which is performed by just grabbing the thigh and the calf and gently rotating the leg in and out. It's usually hard to do formal range of motion on older adults. They tend not to relax enough to do it, so a log roll or hip roll is really the easiest thing to do. And if they have pain with that and they won't weight bear, almost certainly they have a hip fracture. And I would treat that patient very gingerly until you get x-rays and know for sure whether they have a fracture or not. So the most common thing is an obvious deformity, and that's very easy to diagnose. That should never be missed, but some patients won't have any deformity, and then the clues will be tenderness and inability to bear weight. Well, obviously, when you transport a hip fracture patient, you want to be very careful to manage their pain. Pain can lead to all sorts of complications, including confusion and distress. When you are in a lot of pain, it activates your fight or flight mechanism, can increase your heart rate, increase your blood pressure, can actually cause heart attacks and strokes. So we want to treat people as gingerly as we can to keep them comfortable. So using the usual techniques to keep their hips stable while you transport them is very important. Trying to keep the patient calm, and where appropriate, giving pain medication in the field. We really encourage the idea of treating people with pain medication prior to transport and transporting them as comfortably as possible to minimize the risks of activating their fight or flight mechanism. And we've worked with the EMS control at the hospital to be liberal on how we manage that pain medication and gave them good guidelines. So you should be able to call in, if you're transporting a patient to Highland, you should be able to call in and get authorization to do pain management right in the field. And that's really probably the most important thing. People do bleed into hip fractures, so trying to keep the hip stable while you move them can minimize the bleeding and minimize the pain.
Hip injuries, it's interesting to look at the textbook description of what should be done for a hip injury. And they'll talk about putting a person on a backboard and having them very well padded. Some of them will describe a very long splint to go around the leg. And then we look at what is often used in the field where the patient will just be moved with as little movement as possible. So if they're found on a nursing home bed, well, we'll perhaps secure the legs together, either with sheets or cravats, and then we will very gently pick them up right on the stretcher or right on the sheet and move them to the stretcher. And you won't find a textbook that endorses that. But when you think about what are we trying to do, we're trying to limit the movement as much as possible. What kind of movement might we be doing with a log roll and getting that person on the backboard? What kind of pain are we going to inflict on that patient when we put them on the backboard? So that's something to consider. Our goal, anytime we're treating a suspected fracture, is limit the movement of the extremity. How best to limit the movement of the hip. Perhaps it is the backboard, perhaps it is the scoop stretcher. Perhaps we can succeed in limiting that movement just by securing, splinting the legs together and being very careful as we move them, having an awful lot of hands available to move them from one place to another. There have been instances where a patient with a hip fracture has been found in a chair. They've gotten up, they've moved around, they sit down, and after they're having their tea, they discover that their hip hurts an awful lot. And we get there and it appears palpation, it hurts a lot. We've got a little bit of a rotation perhaps. How do we get them out of that? Well, then we have to think about what's the right technique. Anytime you're moving a person laterally, you're increasing the risk of movement to that extremity. So we want to move them on the longitudinal axis. So chair backwards and slide them onto the backboard or slide them onto the stretcher for the transport. And then we're very gentle as we're allowing that leg to come back down into the natural anatomic position.
Perfect.
Another point of preparation for the patient for transport is that we need to make sure that we manage their pain. And this is an isolated extremity fracture. And they're likely to be in a fair amount of pain, and morphine is probably indicated. We want to see what other medications they're on. We want to make sure the rest of their health is appropriate before we give it. It might not be a bad idea to consult with medical control to treat before we give the medication, but it is certainly appropriate for us to give the patient morphine before we move them and before we transport them, because even if we do everything as perfect as possible on the move and the transport to the hospital, it's going to hurt every time we hit a pothole. So we want to make sure that this person receives the appropriate analgesia before we do it. Transport of a patient with a suspected hip injury, we do have a fracture that we're concerned about, so we want to limit the movement of that extremity as much as possible, understanding that we don't want to create an injury as we're doing the movement. So if we're going to put them on a backboard, which is an appropriate way to treat this suspected hip injury, we also want to pad that backboard. Maybe we actually put them on a blanket and then put the blanket on the backboard to help hold that hip still. Same thing if we're using a scoop stretcher, an orthopedic stretcher, that we want to keep that as still as possible and make sure that we're not going to create any injuries, any pressure sores by putting them on too hard of a surface. And again, managing the pain before the transport so we're not increasing the trauma to this patient, and making sure that we take care of them